Good evening, everyone. On behalf of Academy of Pain Physiatrists, we are thrilled to welcome you all to today's webinar. Today, we will explore pelvic pain assessment, and thank you for joining us from various locations. We are honored to have with us Professor Dr. Ravi Shankaran, who bring a wealth of knowledge and experience in pelvic pain management. Sir is the professor and head department of PMR, Amrita Hospital, Kochi. Sir have special interest in spasticity management and pelvic floor rehabilitation management. As you all know, earlier we have also conducted a webinar on pelvic pain assessment, intervention by Dr. Navita Purohit. So those who have not yet watched that webinar, please visit our YouTube channel and please watch that webinar also for better understanding of the pelvic pain management. And please, throughout the session, feel free to share your thoughts and question in the chat box. So without further ado, I will hand it over to the Dr. Ravi Shankaran sir to start the session. And thank you. Over to you, sir. Please start, sir.
Thank you. Thanks for having me. So today's talk is in two parts. The main part is what I was asked to talk on, which is localizing pelvic floor pain generators. The next part is a little bit management, which is different from the prior talk. But let's get to the talk. When you try to figure out what's causing pain in the pelvic floor, there's three types of pain generators. The first would be from the muscle, the next could be from a nerve, the next could be psychogenic. So it's important to be able to sort these things out, and it's not that easy. But as always, starting to differentiate generators starts with just knowing epidemiology. So 1 in 10 men can have pelvic pain.
Sir, your voice is not clear.
Really? I'm not sure how to change that. Can you hear me now?
Sir's voice is clear. Actually, you have to check your connection because voice is coming very clear to me.
Okay.
So it might be a problem of your network connection. Sir, continue, please.
So again, we have to consider epidemiology. So 1 in 10 men can have pelvic floor pain. 1 in 3 women can have pelvic floor pain. 95% of women with lumbar myofascial pain can have pelvic floor pain or even pelvic organ prolapse. So it's not as uncommon as we think. The most common presentation we get is going to be people who have pain in the perineum or in the genitals. The characteristic would be strange kinds of sensations, burning, stabbing, pulling, numbness. They would have had this for about 3 to 6 months. Most commonly, they'd be managed as dysmenorrhea, dyspareunia, benign prostatitis, and intermittent success. The treatment works for a while, then it fails. If this is a female patient, they might actually tell you about family stress. If they're having pain with coitus, they may start refusing sex, and the husband can get very upset about that. Eventually, what happens, many people get labeled as functional disorders because no one can find an organic cause for what's going on. But it doesn't mean there isn't an organic cause. It just means we don't have the skills to look for it. So this talk is to give you those skills. There's a lot of associated symptoms that come with pelvic floor pain. And if you don't ask for these, you won't understand how bad the problem is. So constipation or tenesmus, urine urgency, frequency, incomplete voiding, weak or tight urine stream. They can't penetrate their partner. They can't receive a penetration. They can't maintain erection. They have pain with penetration or impotence, where they can start having sex and go flaccid halfway through. You want to take into account all these different symptoms and rank them by severity of the past 6 months so you know how bad the problem is. History. History is really everything here because history of depression, post-surgical adhesions, endometriosis, cancer, myofascial pain syndrome, irritable bowel syndrome, biomechanics, trauma, infection, all these different things will eventually manifest as pelvic floor pain. It's rare to find primary pelvic floor pain, but these can eventually cause it. So if you don't get these histories, you can't treat them and you can't succeed. The exam. This is what you're all here to hear, so let's talk about it. You can't talk exam without knowing anatomy. This would be a whole talk on its own, which we're not going to do, but we'll go straight to the exam. The first part of the exam is to determine if you have extrapelvic influence. See, the way the head sits on the spinal column will determine how the pelvis articulates with the ground. So you can see types B, C, and D posture patterns. The pelvis in a type B, a kyphotic lordotic posture, will have an anterior tilt, which is excessive. Type C and D have a retronutation, which is a pelvis tilted backwards. Now, all these will start affecting the pelvic floor, and we'll come to that soon. But if you don't examine the spine, you can't treat the pelvic floor because the head and the spine will load the pelvic floor. One more thing. Each of these posture patterns is due to particular muscle imbalances. So a kyphotic lordotic posture usually has a very tight iliopsoas. A flat back and a sway back will have an overstretched iliopsoas, but they differ because a sway back will often have a very weak transversus abdominis. So sorting these things out helps you determine how you manage these patients. Again, why this happens is because muscles have a normal range in which they operate. They can operate and generate power within a particular length. If they're overstretched or overshortened, they can't do that. They develop trigger points, and those eventually make the muscle function in a weaker way. The next step is to look at the pelvic muscles and testing the pelvic muscles. So the most common problem our colleagues have is they think everything is Kegel exercise, send them for Kegel and everything is done. But Kegeling everything is wrong because you first have to sort out, is this a flaccid pelvic floor or a hypertonic pelvic floor? And if it's a hypertonic pelvic floor, why is it? Is it an upper motor neuron condition? Is it non-organic? Is it structural? Is it truly functional? Which muscle is in dysfunction and why? And then myofascial trigger points. So how do we find out what the pelvic floor is like? You need to have a quantifiable and standardized scale. There's two of them. The Oxford is a very cheap and simple one. I don't really use it that much because the Laycock exam on the bottom will actually give you much more information. You can see that acronym perfect. R is going to be power, which encompasses the Oxford scale, endurance, repetition, fast contraction, and every contraction chimed. So this gives you a lot of information. What information does this Laycock exam give you? It gives you MRC, Medical Research Council power, 1 through 5. You're going to examine the pelvic floor, and you can see this clock position. So in the 12 to 6 o'clock position, you have an iliococcygeus, pubococcygeus muscles. At the 9 and 3 o'clock, you have obturator internus. You can find out if these muscles have trigger points inside them. The Laycock exam will tell you neurological control of the pelvic floor. It'll tell you about fatigue and endurance. And this can even link into the next part of the exam. The third step, before the third step, when you finish this step 2 of the exam, you will now have posture patterns from the first part, and then you'll have one of these boxes ticked. You'll either have had a hypotonic painful floor, a hypertonic painless floor, a hypertonic painful floor, a hypertonic painless floor. So this is what we're looking for, and this is giving us more and more information about the pelvic floor, and this exam will even tell us which muscles are now in dysfunction. The question is, if a muscle is in dysfunction, why is it in dysfunction? So the third part is to examine the structure of the pelvis. Now, the pelvis is a ring that has 3 parts, and the pelvis can actually twist. So you can have deformities like a torsion, where one part of the pelvis goes anterior, you can see over here, the other part goes posterior, anteronutation, retronutation, and a sacral torsion, where the sacrum is now sitting at an angle, obliquely, instead of sitting straight in the coronal plane. This will lead to deformity of all the muscles inside this pelvic ring. The muscles originate from within this. So if these bones are twisted out of place, those muscles won't function properly. You could have a nutation, like an anterior nutation, where the ilium tilts forward on the sacrum, or a retronutation, counternutation, where it tilts backwards. All of these will eventually link into Busket's kinetic chains and go up and down the spine from the pelvic floor to the head. So you can have people who have pelvic floor pain that have headaches also. And if you treat the pelvic floor, their headache could go. You treat the headache, the pelvic floor pain could go. It goes both ways. By the time you finish step 3, you will now understand why those muscles are in dysfunction. But it's more than that. You see, this is what the pelvis contains. It contains these 3 organs: the bladder, gonads, and a bowel, right? And they have this bony cage around them. So they sit on the ligaments that connect this bony cage, meaning if the bones are deformed, the organs here may not function properly. If you think about the bladder and the bowel, they empty through the pelvic floor. So if the muscles are overstretched, they won't relax properly, and those functions won't happen, which is why we get dyspareunia, constipation, urinary issues, along with pelvic floor pain. One of the gynecologists from the 1990s, Mario Pescatori, went on to typify different problems. And this becomes very important for what we're doing, because if you look at this back ligaments or the posterior ligaments, uterosacral ligaments, when they're in dysfunction, you can find pelvic floor pain. That's a symptom down here. When it's more of a front ligament issue, you might find stress incontinence, fecal incontinence. If it's a middle, you might find abnormal emptying. But rectocele, rectal prolapse, pelvic floor pain typically come along with the back ligaments being in dysfunction. Pescatori was an OBG who saw a lot of stress incontinence. So he went on to make this model called the Pescatori iceberg. And he said what we see as stress incontinence in urine is just the tip of the iceberg, and there's many other features below. Now, this has been translated recently into this kind of an article for pelvic floor pain. So they've taken Pescatori's iceberg and said, if you have a person with chronic pelvic floor pain, you should be looking for residual urine. You should be looking at obstructive defecation, nocturia, stress incontinence, frequency, bladder emptying, urge incontinence. Because if you don't find these, you can't properly manage the patient. The 4th step is probably the hardest, and this is going to be a bit confusing, so bear with me. But we have to see if the autonomic nervous system is involved or not. And there's no great test for this. So there's indicators of dysfunction. You can see the patient's affect. They might be over anxious. They might be really just fatigued and tired. They would have a history where they failed all the other treatments. They would have yellow flags like magical beliefs that by coming to you, they're going to get magically better. And sometimes the exam could actually be normal to this point, which is where things get very challenging. To explain the autonomic nervous system to you, I have to show you a basic neuronal network, which is what you're looking at. At the top, what we have is the control center. This is the inflammation reflex. It's what helps heal our body. The inflammation reflex has an integrated set point center. It has an efferent limb, which is your sympathetic parasympathetic system. It has a macrophage and monocyte T cells, which are the effectors that get the job done. And you have an afferent limb, which is going to be the vagus nerve that communicates with this. Now, when the set point center says fire, it's going to make the nervous system, autonomic nervous system, fire, and that's going to make cytokine release. These guys become active, cytokines are released, and you start getting inflammation. But this is a good inflammation because it's designed to heal up damaged areas. The problem is, this is not a closed loop on its own. In general, the body controls inflammation, but there's many things that can activate this cycle on its own. And these are things we have to consider. So there's endogenous ligands that come from within the body that can activate this inflammation reflex independently. And that would be HMGB1, which is a nucleolar protein. So if you have a body cell that dies, or too many are dead, the nucleus will go into circulation. The body detects this and it says, okay, there's dead cells, there must be damage somewhere, let's get inflammation activated to clean out those dead cells. Heat shock proteins. Many stress responses, even emotional pain, can lead to heat shock protein release. Uric acid, things we find in a lot of non-vegetarian foods, interleukin-1 alpha, nucleolin. These are all products that the body can actually produce that can activate this. And if they're in too much, you can find inflammation getting out of control. It's not just endogenous ligands, it's also exogenous ligands. So lipopolysaccharides, lipoteichoic acid, which you typically find in the cell wall of gram-negative bacteria. But how do those get into circulation? And the answer really is people who don't have a good amount of diversity in their gut microbiome will have an overrepresentation of particular bacteria. Those can be harmful, and those, when they get into circulation, will produce inflammation. So what makes these ligands activate? How we respond to an environmental stimuli. Today, a patient misbehaves with me, I get angry, heat shock protein release, inflammation reflex, and I might feel sore after. I could have a memory of a patient misbehaving with me the other day. Heat shock protein release, inflammation activation. Bad posture. Bad posture overstretches ligaments, it makes muscles fatigue, it leads to lactic acidosis, endogenous ligand release, inflammation. Pro-inflammatory food. A lot of ultra-processed food sits on shelves for months with preservatives, and this can make a lot of problems when it gets into the circulation because it produces inflammation. Myofascial trigger points, we know it. Aged proteins, advanced glycation end products. They independently attach to myocytes, they produce inflammation and perpetrate inflammation. This is how we end up with an autonomic nervous system overactivity. You have particular segments of the body that keep on giving off pain signals that make the nervous system get overactive. The thing is, autonomic nervous system dysfunction will manifest in somites. So what does that mean? And this is where things get a little bit more confusing, so bear with me. Before we all became who we are, we were an embryonic disc. The embryonic disc has an ectoderm, an endoderm, a notochord, and a mesoderm. The ectoderm forms the nervous system. The endoderm forms the viscera. The notochord becomes your spinal cord, and the mesoderm is interesting because it develops into what you can see here: a dermatome, a myotome, sclerotome, and this is your bones, it's your muscles, it's all that. But this will take a bud from the neural tube and drag it along with it, and that becomes the peripheral nerve that we see in the human body. What you're looking at right now is a somite, and this is all the muscles, all the nerves, the skin, the bones that are innervated by that nerve root. You see, the neural tube will start segmenting. And when it forms segments, this is what we call C1 through 7, T1 through 12, L1 through 5. Those are names we've used to typify these things. But this is how it segments. And when it segments, what you get inside is this: dermatome, myotome, sclerotome. This is what we see as segments, right? You can have people who have a pain generator in the myotome of the L5 nerve root. That will go on sending pain signals into the dorsal root ganglion that don't allow the same viscera feeding into the dorsal root ganglion to function properly, and then you see constipation. So when the autonomic nervous system goes into dysfunction, it manifests in the somites, and it manifests as organ dysfunction. So now you have a person who has pelvic floor pain and they have urine problems, or they have pelvic floor pain and they have constipation. Or you might find a viscerosomatic overlap. And this is where things get very tricky. So when you start seeing more than one system involved, you really want to think about this kind of a problem. So we have this basic immune reflex, the inflammation reflex, and now you have a pain generator happening on that somite level. It keeps on bombarding the dorsal root ganglion on that level with signals of pain. And now that organ can't function properly. And what we get now is a vicious cycle because it might be time to defecate, but the muscles won't work. And the organs start giving signals to the spinal cord, time to go, but the muscles won't relax or contract properly. Same thing for sex. Same thing for urination. So I know it's been a bit complicated, but this is what it takes to really find out pelvic floor dysfunction. And what this all boils down to is this table you find in Janda, his textbook, and this is a physiatrist in the 1990s, Vladimir Janda. He talks about the muscles as contractile and non-contractile components. So the contractile or neuroreflexive components are going to be the neurological aspect. The viscoelastic and adaptive components will be the actual muscle, the rheological part. Now, when we want to find out my pain generators in the pelvic floor, you have to really, really think about what's going on. And you can see the little pictures here. So this is a boss and this is the employee, boss, employee. You have two types of bosses. One is the over-aggressive boss, always angry, never happy, finds problems about everything. And you can see the employee is really overstressed. And you can see the absent boss, the guy who's playing hide and seek, goofing around at work and not doing their job, and the employee who's lazy. So using an analogy, let's talk about the etiologies that will help you find out the pain generators. If the muscle is tight, and we're talking about the neurological angle to pain generators, what you want to look for is limbic system activation, trigger points in a muscle that are driving the limbic system to be overactive, or just muscle spasm that is again driving the limbic system to be overactive. And this is where you find emotional lability, depression, anxiety, a whole spectrum of unneeded emotions in relation to the pain they have. Of course, the result of all this can also be where you find muscles becoming shorter and shorter. And this is a person who wants to keep on stretching, but no matter how much they stretch, they keep getting worse or it doesn't get better. The other side is the hide and seek boss, the absent boss. This is complicated. You see, you can have reciprocal inhibition. If you have a myocyte and its intrafusal fiber that keep on firing, they will eventually block the dorsal root ganglion. They will activate Renshaw cells in the anterior horn cell and inhibit their antagonist. Meaning, if the antagonist for a quadriceps is a hamstring, and a hamstring is always shortened, it can make the quadriceps functionally appear weak, even though the power would be 5. And the same thing goes for the pelvic floor. Arthrogenic weakness. Arthrogenic weakness is where the joint range of movement is actually restricted because the joint is worn down. It's getting osteophytes in it, right? So because it can't move fully through its range of movement, now some muscles are shortened, some are overstretched, and some don't get a chance to work properly. Deafferentation is lower motor neuron problem, is your cauda equina syndrome. Pseudo weakness is your hysterical weakness. Trigger point weakness is the trigger points become scars inside the muscle and prevent the muscle from working properly. And then just fatigue. And how does that manifest in the muscle? Stretch weakness and tightness weakness. So when we want to identify pain generators, we have to do a root cause analysis, and now we have this 5-step exam that tells us what's going on. If you look at this table, it's horrible. It's really horrible. So I want to point out what makes things look different. If you have a person who has a myogenic problem, things could be normal or abnormal, but they should not have a really affected affect. Their behavior should be relatively okay. They shouldn't have this fatigue or anxiety. They also should not be having multi-system problems. It should just be one thing, a genital pain, a urine problem, or a constipation, not all of them combined. if you have a neurogenic pain generator, then what you really want to look at is everything would be abnormal. The nerve is actually messed up, or there is a nervous pathway problem, but you may or may not have multi-system involvement. And then psychogenic. And this is almost exclusively our autonomic nervous system dysfunction. It can look any which way, but they do have multi-system involvement. This is how we sort out pain generators and pelvic floor dysfunction. So again, you can't just say myogenic, neurogenic, psychogenic. You really have to break it down into what's going on, because the more detailed you label these things, the more of a complete plan you can make to treat the person. If it's myogenic, is there an agonist-antagonist imbalance? Is there a cortical representation issue? Are there myofascial trigger points? Is it arthrogenic weakness? Is there adaptive shortening and lengthening? If it's neurogenic, is the entire peripheral pathway from the fascia to the dorsal root ganglion sensitized to experience pain? Chronic pain can do that. Is there a visceral somatic overlap? If it's psychogenic, is there a limbic system overactivity making all this autonomic dysfunction? This is how we sort out generators of pain in the pelvic floor. Most people nowadays are not happy with just a clinical exam and history. They want to have something technological to objectively validate what they're seeing. So you can have diagnostic electrophysiology. Basically, it's just going to show you that if a person moves from unsupported to supported positions, pelvic floor muscle activity will change. And we do find women with incontinence will have increased pelvic floor and abdominal muscle activity with postural perturbations. Many people want to image what they're seeing, and you can't really do MRIs or CTs in this kind of condition, but an ultrasound could show you trigger points, like this one in the rectus muscle. This is the first part of the talk. If the moderator permits, I'll continue with treatment. Should I continue?
Yes, sir. Continue, sir.
Oh, great. So yeah, having told you how to get into pelvic floor pain, if I don't show you how to come out, it's really rude. So I won't leave you in the truck review. We'll show you how to get out of pelvic floor pain and how to manage your patients. So you always need to have outcome measures. And this is going to be your visual analog scale. It's your myofascial trigger points. It's your symptoms. It's your exam findings, the affect, the daily activities, and quality of life. You already know this. So what are the management options? I want to breeze through some of these because they're kind of common sense, but they fall into three categories. Exercise programs like postural correction, pelvic floor exercise, breathing correction, pelvic floor EMG biofeedback. Lifestyle modifications like mindfulness techniques, diet control, weight loss, activity modification, ergonomics, and body movement practices. And lastly, interventions. So hydrodissection, nerve blocks, and neural therapy, which most of you may not have heard. This is the treatment directly for the autonomic nervous system. So again, once you know the posture type, you have a pretty good idea of what muscles are in a state of imbalance. You must correct these. If you don't, their pelvic floor pain might come and go, but their back pain might reemerge. Again, these are all due to very specific muscle imbalances. Kendall, the muscle testing book, will tell you exactly what those muscles are, and it's relatively accurate. With regards to pelvic floor muscle exercising, you can stretch tight muscles, you can strengthen loose muscles, you can have a therapist do a trigger point release. Again, I'll say it, is Kegel really worthwhile? The only time you really want to be Kegeling is if you have flaccid and painless pelvic floors. If you Kegel on a spastic or a tight or hypertonic pelvic floor, it's going to make more pain. Don't do it. I normally never include a physical therapist in these things. I teach the exercise myself just so I know what's going on, how they respond, and how they change with treatment. But it's entirely how you want to practice. Breathing mechanics is really, really important. When a person takes a breath, the pelvic floor will descend. When they exhale, it's going to come back up. And if a person can learn to breathe properly again with a normal pattern, these things can reduce the hypertonia in the pelvic floor. This is a very simple tool. It's very useful. EMG biofeedback, I think we've all seen it. You have an EMG probe, and the probe can either go into the rectum or it can go onto transversus abdominis. Typically, if I'm treating a pediatric patient, the family wants nothing to do with things in the rectum, or the child doesn't want it. So we put leads on the transversus abdominis, and you can teach them how to contract and relax the pelvic floor muscles using this. Lifestyle modifications are kind of common sense, but if these people don't learn to control their thoughts, they will have intrusive negative thoughts. Intrusive negative thoughts that will eventually make them more and more overactive, paranoid, anxious, and make their pains worse. You can do it however you like, whatever works for you, but this is really important to look at. The basic 6 pillars of well-being. So really working on nutrition, regular exercise, if they have addictive substances, stress control, good sleep, etc. All these things, it seems like nothing special to do, but it's very, very important. And you would have made a personal connection with the patient by looking into these things, because most doctors don't. I'm stressing nutrition just a bit. You can see this normal body habitus person where the pelvic floor and the bladder sit. Here's a person with this big chunk of fat in their abdomen. It's pushing down the bladder to hold all these organs in place. The pelvic floor spasms and pushes back up, but that means it can't relax when people want to defecate, urinate, or procreate, which becomes a whole problem. It's not just about being fat, though. Here's a newer study that shows us the microbiome in the vagina or the rectum directly contribute to chronic pelvic pain. And typically when they say this microbiome issue, what they mean is a lack of diversity or overrepresentation of not so helpful bacteria. And there's species that are very helpful, there's species that are not so helpful. You want a mix of both. But the question is, how do you promote diversity in your microbiome? And that would be a whole food plant-based diet. So with these patients especially, you want them to be having half of their daily intake as fruits and vegetables, water, 1/4 as grains, 1/4 as plant proteins. This is not a popular diet. People in Kerala hate it. They love their rice and beef. But that's how it goes, and this is how they're going to get better. If you don't do this with people, they'll improve to an extent, but not enough. Activity modifications are what we always know. I'm not going to spend time here, but it's for completion's sake. Ergonomics, again, if you sit in a chair and you don't have back support, the pelvic floor muscles tighten up even more, or they can get overstretched. So do use the backrest of your chair. Do make sure you're sitting up and erect. This is a hard thing to explain, but it's body movement practices. And there's 2 of them that are relatively well known. They're not really established in India that well, but Alexander technique and Feldenkrais are the 2 things. I've been practicing Alexander technique for about 15 years now. It teaches a person how to become aware of how they're using their body so they don't put it to unnecessary stress. And that's really the easiest way to describe this. It takes a lot of time, hands-on, to really get the hang of it. But once learned, these things can immediately reduce pain. The last part is visual analog scale and pain. This is for intervention. So if your VAS is 5 or less, you really want to focus on the lifestyle interventions and exercise interventions. You don't really need to worry about injections. Of course, if it's more than 5, I start thinking, is there no myofascial trigger points? Does the pain go along a peripheral nerve distribution? If it does, I'd say do a trial of nerve block. It's worthwhile. If there's no change, reassess. If there is a reduction, you want to think about going back to lifestyle modifications and exercise. Now, trigger points can manifest as vague neuropathic pain. And this is where things get tricky. So if your nerve block doesn't work, you might actually have latent trigger points that are not active. And you may or may not be able to feel them. And this is where things get tricky. But if you have trigger points, You can always do prolotherapy, or you can do a trigger point injection. You can reassess the pelvic floor. If you still have trigger point, there's no surprise. You can do 4 rounds of prolotherapy and it's still okay. If they have no more myofascial trigger points, you really want to go back to lifestyle and exercise. Now, the last thing is our autonomic nervous system. And that's when a person has what everyone calls psychogenic visceropathy, where the organs function normally, but the people swear they're not working well, or all the normal testing shows nothing abnormal, but they can't urinate, defecate, whatever else. Or they have a visceral somatic overlap. And this is where we talk about neural therapy. So neural therapy is a treatment where we inject autonomic ganglia to reset them so they can function better. And usually for a person who has no organic lesions. Many people come and ask me, hey, can I do these YouTube videos? It's very popular on the internet right now. And my answer is, fine, go ahead. If you can diagnose what you have, you should do whatever you like, which is really never a good answer, and they understand that. I'm going to share with you about 5 years of experience in a little flow chart here, so bear with me. But we have people referred for pelvic floor dysfunction, and we get a history and exam. And then from there, we look at lifestyle and exercises. And if they get better, great. If they don't get better, I'd probably add EMG biofeedback. If they get better, awesome. If they don't get better, we start thinking about interventions. And again, if they're better, we're happy for them. That's great. If they're not, maybe we need to redo the history and exam. And many times people don't tell you everything in the first encounter. It takes a few encounters when they get comfortable to tell you what's actually going on. I had a young woman come in pelvic floor pain, urinary frequency. By the 5th encounter, she told me how rough her husband was with her when they were having sex, how she didn't like it, and how he was going hard and fast on her. It takes time to develop that trust to get these real histories to make a proper treatment plan. That is the basic algorithm we follow right now. But of course, patients don't follow algorithms. So what we've learned is, here you can see, if people don't really cooperate with the history or exam, some people come in, they expect Kegel and nothing else. They don't get the right outcome. They often come back miserable. There's a handful of people where you do lifestyle exercises and they're not really going to get better. We would put them into EMG biofeedback. But again, if they're not responding, it's a bit of a problem. At some point, we had people come and tell us, hey, this EMG biofeedback was the best thing, and you should have done the exercise with me. So what we did is we tried sending people straight to EMG biofeedback. And of course, they had a poor outcome. And the thing is, the entire body is connected to itself. So if you're not treating the lumbar spine and the posture, you can't really treat the pelvic floor, even if you just do EMG biofeedback. At some point, all these people that do well will need a personalized program that looks at all these different factors that make them unique. And the people who have a poor outcome usually come back and say, hey, can't I just do yoga? It's a very popular thing. And I tell them, yes, you can do whatever you like, make yourself happy, but do keep in mind, there's people who do yoga that come to me with pelvic floor dysfunction. And if they understand what I'm saying, they know they have to stick to the program. If they don't, they can be happy, it's fine. So you've seen a lot. People often wonder, where can we learn all this? And we do host workshops and we do have a fellowship. Does anyone have any questions? Any questions?
Thank you, sir. Thank you so much for such a nice presentation. Sir, we have a few questions in chat box. Sir, first, yes, sir. Sir, how to diagnose levator syndrome clinically and how to treat it?
Wonderful. So I'm going to be a bit snarky, bear with. But what we call levator ani syndrome is just a name for a condition. It's still pelvic floor dysfunction. But if you were to say it's levator ani syndrome and nothing else, then it should be a purely myogenic trigger point, meaning you do the Laycock exam, you look at the different clock positions, and you'll find out which muscles are generating the pain. This should always be in the 12 o'clock and the 6 o'clock positions. Those are your muscles that are going to cause that. You would feel trigger points and then you can inject those. The problem with levator ani syndrome as a name is it implies levator ani is the entire problem. By treating it, everything goes away. Why is levator ani in dysfunction? That's the whole problem. Once we get to that, then we can really treat the person. But yes, you could treat a named condition and not be wrong. It would be okay. Any other questions?
Sir, one more question from Dr. Megha Bhargav. Should pelvic floor dysfunction be suspected in women with chronic lower abdominal pain without an infectious or menstrual or intra-abdominal causes?
It is definitely worth doing. There is a particular condition called painful bladder syndrome. It presents as anterior abdominal wall pain, not pelvic pain really. And that can have a pelvic floor dysfunction associated. Now, the tricky part about the work I do is I get them after everyone else has worked them up. So we get all these waste cases. They're good people, but they're suffering and no one can figure out what's going on. Meaning, is it to say the pelvic floor is the primary problem making a painful bladder, or the painful bladder making the pelvic floor pain? It's hard to say, but it's definitely worth examining the pelvic floor and then treating it to see if they get better.
Yes, sir. Sir, one question, two, three question from my side. Sir, do you have any assessment pro forma for pelvic pain assessment at your institute? If you have, please share.
Exactly what you just saw.
Yes, sir. Sir, the pain during urination in a middle-aged females. Sir, what are the differential diagnosis and how to rule out clinically?
Pain during urination.
Yes, sir. In a middle-aged female.
So this is tricky. There's
Yes,
no
sir.
straight answer. And part of the problem is I'm a little bit blinded because my colleagues do all that work for me.
Mhm.
So there is interstitial cystitis, there is recurrent UTIs, there is painful bladder syndrome. There are a variety of different infections you should rule out and malignant conditions. None of that I deal with. My colleagues do all of that. If there's a history of radiation, you want to look for radiation cystitis. But what I end up looking for mostly is just pelvic floor dysfunction. Everyone else has done all the big things and no one can figure out what's going on. So that's the limit of my knowledge. Sorry.
Sir, one more question. Any ergonomical advices for dysfunction improvement or management of pelvic floor dysfunction?
And this is tricky. So again, what we tell people to really, really keep it simple is, you can see that ischial tuberosity. I'm trying to hide from my own background. There's ischial tuberosity over there, right? On that scalp, on that pelvis. So the ischial tuberosity is what they should be sitting on. And when they're sitting, they can feel both the ischial tuberosities. They would have, in some form, maintained a lumbar lordosis when they're sitting. Their head would be sitting on top of their spine rather than ahead of it. And that would be enough ergonomic work to not overstretch the back muscles or the pelvic floor muscles. It's hard to show it over a small box like this.
Yes, sir. Yes, sir. Sir, a female patient is complaining of vaginal pain, and on examination, the tenderness present in the lateral and posterior wall of the vagina. Sir, what will be the should we suspect and how to treat it? Is a
So
question.
whenever I do pelvic floor exam, that's one place I stay away from.
Mm.
As a male, women can get very uncomfortable with that. If it's a woman who's already had children, the exam may not be useful because everything could be stretched out. So you could be falsely thinking the muscles are weak when they've been used, right? So again, the way I work is everybody sees the patient before me and they rule out all those things. So OBG would have done a colposcopy, they'd have looked for all the infection, they'd look for mucosal tears, tumors, and that sort of thing. So if a person, what's the age? Middle age, huh?
Yes, sir. Female patient.
Middle-aged female patient with posterolateral wall pain, assuming everything else is otherwise normal, you would be thinking about the muscles. And you could go through per rectal, go into the 3 o'clock and 6 o'clock positions and find operator internus is painful. And if it is, then you know what the muscles are, and you could treat those.
Yes, sir. Thank you, sir. Sir, have you encountered ilioinguinal neuralgia or genitofemoral neuralgia in female patients, and how you clinically differentiate uh, during your practice?
Tricky again. You'll see, I don't really go to sticking a label on a person. If I believe that it's from a peripheral nerve, we'll block the peripheral nerve. If they get better, we're okay. So it's a little bit tricky because the times I've had to do nerve blocks are either when a person has a lot of functional overlay. I think the first time I did it was a guy who had cheated on his wife with a woman who developed HIV. So he had pain everywhere, and you inject one nerve, the pain goes away, and the next nerve area will pick up, right? So more than injecting a nerve and blocking the pain, you want to figure out what's driving all of this. And if you have multiple nerves involved that link into a somite, you could still say it's autonomic nervous system on some level and treat that. But I think just last month I injected a guy's ilioinguinal nerve. He came back saying he was even worse. So it was really strange, but it turned out he actually had a hernia. And the
Yes,
hernia was pulling through the anterior abdominal wall, stretching the nerve. And it wasn't there before. And it's because the urologist did something on his spermatic cord. So it's not that straightforward, but I think what we have in modern medicine is a tendency to put terms and labels on things, and you treat the label, but you don't treat the person. And it's not a problem because you can, at some point, you have to ask, why does this person have these problems? And the
yes.
deeper you trace it, you'll eventually start finding out what's actually going on. Any other questions?
I think no more questions.
Was that too much repetition from the previous talk?
No, sir. No, sir. Thank you so much, sir. If anyone have any question, you
Someone
can
put
ask.
economics in the box.
Otherwise, we will wrap.
Oh, good. Okay, cool.
Dr. Minaj,
Excellent,
you
sir.
want to ask any question?
Excellent, sir. It was a very nice presentation, a very detailed presentation, basically. So thank you, sir, for the great extensive knowledge of the trigger points, muscular myogenic component, immunogenic component, and the psychological and postural aspects. Thank you, sir.
Thank you, sir.
Great. Good night, guys.
Good night, sir. Good night, sir. Thank you so much, sir.